Shark attacks are real, just like Mike Lowry from Bad Boys is real. So, on this episode, Mark's not with us, Kathia's not with us, which is exactly what happens to you when you try to replace me and Walter with people. It just doesn't work out at all that way. And you guys always kidding me about having all these 1 year pins. Well, I, on this episode, have found us a physician that has more pins to pin in as to where they are. In this episode, we're going to have Mike Lowry. Dr. Mike Lowry. That's my Bad Boys impression. That's the best I can do.
That's
But
good.
John, Dr. Lowry may have more pins than you have, but I bet you they're more than 1 year pins.
I, I mean, that is true. That is true. Uh,
And John, we're not
just a straight bet. Go ahead, Dr. Lowry.
well, Dr. Lowry, who comes from us from, let's just name them all. See, we've got Bertie, we've got Carteret, we got Chowan, we got Washington, Terrell, not to mention private services, community college. Man, you have a lot of hats to wear. All those hats, however, are beautiful. Terry's cowboy hat, not so much.
Don't hate it.
It's missing a brim.
Whatever.
Thanks for having
Turn.
Um, Now, I'll tell you what, Dr. Lowry, if you would just give us a rundown a little bit about your background and what it is you do, and then we're gonna attack you like this shark behind me with questions.
I wish it would eat you.
It's an Outer Banks shark.
I wish it would eat you.
Well, I started out in my training at ECU. At the time, it was called Pitt County Memorial Hospital in Greenville. Did my residency training there. Did medical school at UNC. Pitt County Memorial Hospital, of course, is kind of morphed into University Health Systems of Eastern North Carolina, and then it became Vidant. Now we're back to ECU Health at this time, and I've always worked in Eastern North Carolina. Spent my early years in Eastern North Carolina. Definitely was a thrill to come back, and have worked with EMS agencies since my time rotating through during my residency back through ECU, and I've enjoyed the ride. I've done EMS medical direction now for closing in. I think I'm about 25 years. If you have a close up, you can kind of see a little silvery lining in there, but yeah, have enjoyed it, quite a bit. There's definitely been a need for support and advocacy throughout Eastern North Carolina, and seems now more than ever we see it.
Did you grow up wanting to be a doctor?
I grew up wanting to help people. I knew that. Like we are saying before, the dopamine release, the endorphin release you get from helping other people in any form or fashion, and with emergency medicine, from 911 dispatch to EMS to the in-hospital side of it, it follows all the way through. Even when you go home and you've completely gotten your butt kicked. Actually, do you guys edit out cuss words?
We try
Never.
not to.
Okay, but when you come out and you don't know where you're wiping because you think you got ripped a new one, we'll just put it that way. You still come out saying, "Hey, I made a difference in somebody's life," and who knows, it may have been made a difference in somebody's death with regards to kind of helping them go through it peacefully or comforting the family, but you still have an impact on other people's lives in a way that's just beyond measure. And so it was, something I had interest in doing from a very young age. And with,
I was gonna say you definitely made a good decision being a Tar Heel. I have to give you that one.
yeah. Actually, I should have put on my Tar Heel stuff, but I didn't know. We may have some Dookies out there, somebody from state, or who knows.
They'll be all
Nobody's
right.
perfect.
Yeah,
They'll be all right.
live. They'll live.
We don't
They'll
have
get
to
it.
worry about them for the state guys. We don't have to worry about for another 40 years. They hit their
Yeah.
Final Four this past year, so we're good for another 40.
Oh, ouch.
Dr. Lowry, every time I see you, I feel like we're about to go bust a drug ring. So I appreciate you taking some time to spend with us. And so the role of medical director, some folks might think they know what it does, and it, what would be your description for that person who wants to be that future EMS officer? What does that medical director do? What is their role in that organization? What are some things that you bring to the table as the medical director?
It's of course, North Carolina Medical Board requires that oversight to take place. And it's not that people, function underneath my license. It's just within the supervision. It's just, because EMS practices independently out in the field. We were talking a little bit earlier about how nursing has got the backup and support right there almost all the time in the hospital setting, and they've got people they can talk to and kind of confer with. If there's set regimented orders to follow. With EMS, they're out in the field, making the diagnosis, going through the physical exam, and then finding the plan to implement and then implementing that plan. And they're having to do it pretty much in solo until they bring the patient in. Medical direction, can be in the form of the practitioner on the phone, trying to give them guidance when they have questions, or confirming the pathways that they're going through with. From the standpoint of medical direction on the state level and working individually with counties and agencies, it is largely a position you want to ensure the proficiency of all the providers that you have through initial credentialing and testing. You need to make sure the continuing education that they have is robust, challenges them, closes off the gaps that you may find that through practice and working with the county, issues that come up with QA, issues that get reported. It's want to kind of watch out for them on a personal level, and as we were saying earlier, kind of help them with their career choices and trying to keep them involved in emergency medicine, which is extremely important right now. There's quite a bit that you can do to advocate for them within the county government structure, with regards to trying to retain them, trying to make sure they're being valued financially the way they should be, and being a resource for any questions that they have or anything, and trying to advance some of the latest implementations and some of the newest things that are available. North Carolina is extremely advanced with their EMS system as compared to other parts of the country. It's not just our reporting, but it's what we allow our EMS providers to do. The Not uncommon for me to get somebody who's coming down from Ohio or somebody from Pennsylvania, and they're like, "What? You guys
Yeah.
can do that? Oh my gosh, we can't give ketamine. We can't give, we don't do that." There are quite a few areas that are basically just ambulance drivers, pretty much, and they coming down here, it expands their scope of practice and their capabilities quite a bit.
Dr. Lowry, I would agree with that. John and I, a few weeks ago, were at a Credicon, and you have representation from a large portion of the U.S., and that's one of the things that we hear as well. And I'll use the example of AEMT, and they're like, our AEMTs can only start IVs and give glucagon, or start IVs and give D50. That's it. We didn't realize y'all could do all this other stuff. So I agree with North Carolina being advanced on that, and you hear a lot of medical directors say that. I don't know if crews quite understand that or paramedics understand that, but if you just talk to other states, you gather that very quickly, how progressive we are in North Carolina.
And that was, they just did a scope of practice change. with the AEMT to increase that. Dr. Lowry, how has that impacted you and the agencies that you oversee? Has it impacted you at all? Do you see an AEMT need, or do you see it declining, rising? What do you see?
Yeah, I think with the expansion in the scope of practice, it's going to make them more of a integral part because they can do more. One of the things that we are seeing is that we're seeing more and more vacancies for paramedics now. This is multifactorial. You saw COVID make a lot of people that were doing it because they enjoyed it just all of a sudden decide, hey, this is too dangerous for me. Why am I still doing this? And they dropped out of the workforce. We had, of course, some that lost their lives to COVID also, but we're seeing that there's more and more of a need for paramedics, and a lot of agencies are running sometimes, gosh, 20, 30, even 40% down on their ideal number of paramedics they would hire. I could give multiple examples, but I know of one county at one point was literally running 55% of what their normal staffing model was. And to backfill that, they were, putting advanced EMTs in place of paramedics. They were running QRVs all over the place, and they just had some trucks which were shut down. So we are using the advanced EMTs to backfill for paramedics, and then also have now carving a niche out for them to practice more independently. And so it's going to be a big boon for all of us.
You think it sort of forced the door open a little bit to say this might be the avenue of the future to look at, instead of looking for paramedics being a place on an ambulance for transport? Maybe as a conglomerate of things, and Terry may can talk a little bit to this as well because he probably sees that data more frequently than I do, and that is, between community paramedicine being out there, the facets that are involved with that, the expanded scope for AMT and COVID, it seems like it's opened up a door to sort of drive that QRV that you mentioned, and having someone not necessarily being on the ambulance, but going out to the house to evaluate those that do need it. And I think, and Walter and I, he mentioned we were at Credicon. One of the things they talked about, I think it was Dr. Myers that was talking about the gravity of AI technology coming into EMS and how it's going to be a part of EMD, potentially self-driving ambulances, the stuff that we use in our education, all these things. Did we get forced now in this thing to have to evaluate this QRV model? Terry, was you fixing to say something about that?
What I was going to just say is I think one of the pieces is those relationship pieces, whether it's the agency person, the medical director, the state. And one of the things, kind of to piggyback off of what Dr. Lowry was saying, is the state of North Carolina, with their progressiveness in terms of this scope of practice increase for advanceds. And what an advanced is now is, it reminds me of the old advanced intermediate 25, 27 years ago, with all the things that an advanced can do. But I think we do begin to say, well, now we have the tools to shift the model. Do we continue to do business the way that we used to, or do we start to make that shift, especially with community paramedicine, with the scope increase of advanceds? And I think at least having that conversation about it.
And yeah, the shortage of paramedics, we were mentioning some of the causes on it. One of the larger causes is the fact that we now are allowing, EMS providers to practice their skills in the hospital setting. Carteret County, we were the first in the state of North Carolina to work it out with the Board of Nursing 20 years ago to allow our EMS providers to actually practice within the hospital setting and perform their skills. Prior, and this was, gosh, I think it was 2003. I think we finally got it through. It was something I'd been working on for a couple of years. But the nursing board of North Carolina would not allow an EMS provider in the hospital setting to practice any of their skills. I mean, once they crossed that threshold, it was all Board of Nursing and it was blocked. And we were able to get it through for them to practice their skills in the hospital setting. Now it's been expanded. It's been relaxed a good bit where this has opened up a source of talent, a source of labor in the hospital setting to meet with the tremendous nursing shortages that we're seeing. And so there has been a rather large exodus of EMS providers leaving the 911 pre-hospital setting and they're working in hospital settings. As we were saying earlier, it's a great transition point for people when they can't do the lifting, they can't do the 24s, but it's also some are choosing this a lot earlier just because they're paying more in the hospital setting. The hospital administration, they're sitting there saying, hey, I could pay, a nurse, and we won't throw figures out, but I could pay them X. I could pay them X minus a good amount and get a paramedic. And guess what? They can do pretty much everything the nurse can do. Or I could pay 3 times that amount and get a travel nurse, which is what most of them are regrettably having to survive with. And the beauty with the EMS providers is they're talented, they're experienced, and they're great with like differentials. They're good in triage settings because they're used to seeing somebody who they don't doesn't have a diagnosis stamped on their forehead and having to work them into pathways on which way to go. And the EMS providers, they can back up respiratory therapy by giving neb treatments. Heck, they can intubate. They can give, quite a few different medications along that line for, even conscious sedation. But, of course, the nursing board keeps their restrictions in place. A paramedic will, lose their license if they are handing out Flexeril muscle relaxers or Bentyl for stomach spasms because that's not on their formulary. And those are simple, pills that really are nothing compared to ketamine and propofol and succinylcholine and some of what EMS is allowed to give.
So you had a front row seat on that on seeing that. So that just spawned me to have this question. Sitting there seeing the integration, sitting right on the front row of seeing the integration of EMS actually coming in to perform in the hospital setting. Did you see any changes in sort of the quality that happened there? Do you think that was impacted at all?
I would say the experience was really good. They were extremely talented at code resuscitations that were in the hospital setting. They were phenomenal at putting in IVs. And then you could, if they and at Carteret they would be doing blood draws, giving the medications within their scope of practice, helping out with triage processes and everything else. And then if a interfacility transport had to occur, they could hop on the back of the truck and transition to that, to clear the emergency department out. So I thought they were a welcome asset and really augmented what we were able to accomplish. Again, with the nursing shortages that we have, and they're not going away. They're not getting better. And if you look, further down the educational pipeline, we're just not cranking out enough, and we haven't been for a long period of time. So you're seeing EMS kind of backfill some of that. And again, it's hurting our 911 capabilities because they're not available in that avenue.
So we have a shortage of nurses, and then paramedics move from the field and go to the hospital. And that creates an even worse shortage for paramedics, which causes systems to change how they utilize that. How do you control the cycle? I mean, eventually you're just going to be out of people to backfill with. I seen somewhere the other day where there's systems now hiring emergency medical responders just to drive, truly being the ambulance driver, and then having EMTs available. So you see all these strategies coming out there. This has become robbing Peter to pay Paul in the
Right.
healthcare system in general. So,
Well,
um,
if you look at the staffing waiver, COVID brought out
Right.
the North Carolina Office of EMS staffing waiver, in which you literally, just like you mentioned, you were hiring ambulance drivers. And if you were looking at it, there was no credential for it. They didn't have to be CPR trained. They didn't have to be EVOC, trained. They just had to drive.
Be a
And
good
so
person.
yeah, you're getting the bus drivers, the people that were doing some, other transports. I mean, just pretty much anyone to do it. And that was supposed to be in response to COVID to try to match the numbers. So we're seeing extension after extension after extension. The most recent one from I think it was from last month. They actually have extended it one more year, whereas before they were going, I think, 4 to 6 months at a time. They just said, "Hey, this is not going away anytime soon." So yeah, it's as to trying to fix the issue. We're doing whatever outreach we can in high schools, trying to make presentations, trying to get people interested in careers in EMS, careers in healthcare in any form or fashion. But there's just not enough enough of it. The demand is ever rising, and all the rest of us are just getting older. So,
Dr. Lowry, I got another question for you.
yes,
We
sir.
talk about paramedics coming into the ER to be able to help with the nursing shortage.
Mm.
My understanding is there is an emergency physician shortage
Mm.
that we have seen coming into the emergency rooms as well. There's been some push nationally for the paramedic to be a mid-level provider. How long do you think before we actually see that?
Yeah, the I think there's going to be an evolution towards like transitional courses that allow you to progress on to being a mid-level provider or having, some independent, scope of practice duties. I mean, if you already look at what, community paramedicine is doing and what they're accomplishing, and very effectively doing it and very cost effectively doing it. Gosh, if for those of you who recall, at one point, a nurse could end up challenging the EMS exam without, having any
Uh,
specific training at one point. And they could,
They could challenge the paramedic exam.
yeah, they could challenge any level they wanted
Right.
with it. And then we've kind of backed away from doing that. Certainly as EMS has kind of expanded their capabilities and their knowledge base, and you see the number of training hours required just by itself. It's not quite that flexible, but whatever that they can do to kind of reach that next level. For nurses, the next level, of course, is nurse practitioner. So they go from associate degree to a BSN where they add on courses, and then they can get nurse practitioner degrees. So the thought would be, you go, EMT or medical responder, EMT, advanced EMT, paramedic. What's the next transition point? What we were saying earlier, that I've done everything I can to try to help EMS providers make that next jump, which is PA school. Some actually make the next jump, into medical school, and they do phenomenal in that setting. Having worked with several other medical students that had previous careers in EMS, they were coasting right through it. They're like, "Oh yeah, I know what that is," and they were able to apply the clinical knowledge that they had to some of the science to back it up, and they'd be like, "Oh wow, so that's why we did that," based upon some of the science that we were learning, and they were just heads above everyone else going through rotations and with everything else that was being done. So, I do see that next transition being paramedic to, a mid-level provider. And I think PA school would probably be the best way to do that. Now, do you have to go a full 2 years through PA school to do that? You could probably come up with a transition course that you're allowed to do that in 1 year. I have uh, many a time have said that I could take some polished paramedics, seasoned and tenured, most of them that are involved in education, by the way, and could take them and throw them with maybe a month of training into an emergency department and have them impersonate a mid-level provider, heck, impersonate a physician, and they could probably get away with it and could do it successfully. You know, look up whatever it is they don't know, but they could get away with it. You know, that base of training that is there, that experience that the paramedics have, it'd be a very easy transition, and it has been a very easy transition for those PAs I've worked with that have worked in EMS.
Problem is we go back to how do we keep them on the ambulance?
Hmm.
Yeah, that I know.
That's the problem. We go back, and and that's the question that everybody asks. And I still, and I'll use what you said earlier. I had two students last week that said, "I'm trying to get in EMS, A, because I want to teach, or B, I want to work in the hospital." That's the two things. They don't really want to ride an ambulance. They want to teach, or they want to work in the hospital.
Yeah, I mean, what's the loss for 911 is a gain somewhere else in the healthcare.
Right, 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 right.
That's the reality of it.
It
Uh,
is.
and I'll, pass this on. I'll get nursing assistants that have other interests or want to expand on further. We'll get, candy stripers going through. And the thing is, anything you do in healthcare, well, even a unit clerks, anything you do in healthcare, that knowledge that you build up, you can use that to progress yourself into something else. I've actually got, I know of a few unit clerks and nursing assistants that are now paramedics that, progressed from that. I mean, they started off with medical terminology and not touching patients and, answering phone calls, but they learned enough about it just from that where they could, move on to something else in healthcare. So maybe what we're losing to the hospitals, we need to steal from somebody else.
Right. No, that's correct.
Dr. Lowry, how do you stay updated with the latest advancements, best practices in pre-hospital care? You're talking about 25 years, a lot of things change. And so what's something that you do to stay up to date and to stay abreast of what is old and new and what is changing?
Well, yeah, certainly listening to podcasts of people that know what they're speaking about. Jim's magazine, going to conferences. It's one thing with healthcare is, and I'll pass this on to people in several different settings, is this is a career in which you have got to consistently challenge yourself and realize when you think you know it all, that's when you screwed up. Because, I am hoping to the last day that I work, the very last shift that I work, learn something. And, if we can't learn something scientific or a little clinical twist or something with our decision-making skills or, history taking or physical exam skills, maybe we'll learn something interpersonal or a different approach to easing somebody's pain or something, something that may be a little bit more esoteric to the science that we think we're confronted with. But this is something that it's fun, it's entertaining, it's challenging, it's never boring. And it's something you've got to continually put yourself into positions where you've got an opportunity to learn and double check things. What I what I used to do back in medical school and residency, and even several years into my training, is I carried a 3x5 note card with me. If when I wore a white jacket, kept it right there at all times. Later on, no white jacket because it scares people off and carries germs. I'd stick it in my pocket or in my wallet. Nowadays, you just kind of stick it on your phone, and I've got a little section on my phone, which is it's basically I've got one that's EMS issues and I've got one that's medical issues, and it's questions that I have on things that I need to go brush up on because you're never going to know it all. You're going to forget some of it, and there's going to be some new advancement, some new chemo drug, something else that I'm not going to know. So I go and look it up. And if, I have spare time, I'm looking at the file on my phone and, crossing things off the list. So,
I like how you say if I have spare time, not when.
yeah.
Right.
Hard to make some. There's only but so much caffeine that you can ingest.
So you're working in a coastal community. So tell us about how many shark attack victims you've had.
Haven't had too many. I probably literally about a total of 10, of which, yeesh, I'm gonna say
Which
6.
11 of them were not really shark attacks.
Yeah, it can be. You end up pulling out broken glass out of their foot or something like that. But no,
Correct.
but yeah, I'd have to say, of those, there are probably only 2 or 3 that were even kind of registered much of anything or were even limb threatening.
Just hypothetical. Abducted by aliens or bitten by sharks if I'm standing in the ocean.
Well, John, when we take you out, swimming with us, we bring you along because we can all swim faster than you, and so we know we're going to be okay.
Yes,
Um,
sir.
and then, we also hang that pork chop around your neck on a tether, and that tends to help out a little bit. But the sharks don't like the way we taste. And so they usually run the other way. If you see a pod of bait fish that's going out there and there's a frenzy, don't go out there
Correct.
to investigate it. The other
Yes.
thing is, I surf, and now I old man surf, which means that you get on a paddle board, but you don't wear like flashy silver jewelry.
Like
You,
that gold chain, that big gold chain you take off.
yeah, man, if you
About the
got a
Lowry.
gold tooth, you better not be smiling too much with it. Yeah,
Oh,
I won't put my gold out there. So, I mean, there's certain things that you can end up, doing, but the risk is just not there. I mean, I've been bumped by sharks before, but they're usually just trying to feel you out because they don't know what you are. And it's I don't know. We should be able to coexist, but there are some cases and occasions out there where stuff happens.
two things, Wilson. Number one, if you go into your backyard, there are squirrels out there, and they're not killing you. They're not attacking you. Number two, there are more people who are killed by cows annually than sharks, and more people are killed by vending machines than are killed by shark attacks. As my running partner, you should know this.
Where
And
did you get this useless knowledge from?
Hey, he's right.
Terry GPT.
I was going to say this useless knowledge. I don't know where
That's
you got that from. It's useless.
United States Life Saving Association, lifeguards for life, swim near
That's
lifeguard.
just
One
Outer
in
Banks
one in
alone,
1 million.
though, the shark cover up is we're going to expose you. We're going to expose you. We know you're hiding your numbers, and we're going to expose the shark attack figures soon.
I mean, it's been proven 70% of facts and everything that are basically made up right at the time, the percentages and everything else. I mean, it's just all it,
I'm gonna Google that.
kind of comes out of nowhere.
I'm gonna Google that. Here's a fact. I think as we're winding down, is Mike Lowry. Mike Lowry works best with a partner. I would call that a best friend. So who's Dr. Lowry's best friend?
Actually, I practice with my brother, who also does emergency medicine. He,
What?
yep,
You just made that up.
I did not. I did not. He's actually my older brother, who's a little bit ahead of me. He's also my next door neighbor, where I live. And so
Oh my
we,
gosh.
we we collaborate on a lot, and so our dinner conversations tend to drive other people away. And I think he had a weird fascination with blood and guts, dating way back when we used to, clean fish when we were like age 8 and 10. We used to have fish gut fights, where
That's coastal Carolina fun right there.
that's us, man. I know that's can't get any better than that. But when you got some fish roe and caviar and entrails all over you, it's a good time. So But yeah, he practices emergency medicine also, and it's always a great resource to kind of brush ideas off of, and
Hmm.
also somebody to commiserate with and to complain with because he knows it also. So it's good for all of us to have somebody in our corner, and somebody that kind of either shares our misery that we have, or knows what we're going through.
Now, Dr. Lowry, did anyone else in your family, were they doctors besides you and your brother?
Actually, my father was a ophthalmologist.
Okay.
Yeah,
Okay.
and
Okay.
he did everything he could to try to drive us away from medicine. Actually, I wanted to be a truck driver when I was younger.
They need them today too.
Get to see the world, all kinds of stuff.
Right. Right.
Well, we appreciate you being a guest. That's fabulous, fabulous stuff. We appreciate you coming on. I mean, I think this is really insightful. I think folks are going to dig it.
Yeah, definitely.
Thanks. I appreciate
sir.
you having me, and this is great service that you guys put out there. It's always good to have the best and the brightest and the latest of information, and still be watching and waiting to see if the shark finally catches up to John.
I can only hope that it does.
Okay. All right. Thanks, guys.
Thank you, sir.
Thank you, Dr.
Thank you.
Lowry.
Take care.
All right.